Yeah, just that behavioral health is a core component of healthcare. And if you're ignoring it or you're not addressing it, it's going to hinder your practice. It's going to hurt in the long run, and it's going to impact people's health outcomes. I would say if you want to make a dent truly on the ED utilization, if you want to look at things like looking at substance use disorder and the impact of treating somebody's anxiety and substance use and a chronic condition, they're directly correlated. There's lots of great research out there. I'm happy to share with people who want to reach out to me where to find articles that can help justify changes in what your practice is doing with the clinicians in your office. I can help you with things that have been published year after year to demonstrate the efficacy of these services and how important they are.
Welcome to Medical Money Matters, the podcast where you can find experts, answers, and resources so that you can achieve mastery over the financial and business aspects of your practice. Welcome, everyone. Behavioral health has moved from the margins of healthcare to the center of the conversation. Over the past decade, rising rates of anxiety, depression, substance use disorders, and physician burnout have created unprecedented demand for behavioral health services across all care settings. Yet, many physician practices continue to struggle with how to effectively address these needs while maintaining financial sustainability. Our guest today, Ed Speedling, MSW, MHA, FACHE, is a nationally recognized healthcare executive, consultant, and thought leader with decades of experience in healthcare operations, leadership, and especially behavioral health integration. In this episode, we'll explore the evolving role of behavioral health in healthcare delivery, why integrated models are becoming essential, and how physician practices can improve both patient outcomes and financial performance by embedding behavioral health services into their operations. Ed, welcome to the podcast.
Thank you very much, Jill. Appreciate it. Glad to be here and excited to share a little bit with your audience about my world, which has been 17 years of executive leadership in behavioral health and consulting. And I guess I'll just start with saying what I try to do is solve difficult operational problems and help people with optimizing growth potential and looking at their throughput, but also for patients and communities, making sure that we identify the right type of expansions, opportunities, and solutions so that everybody can have their healthcare needs met. And so I think first and foremost, I'm a clinician. And secondly, I'm an administrator and just glad to be here. So thank you.
Thank you. And thank you for joining me. I've been looking forward to this conversation. As I shared with you ahead of our recording, this is the first time in 187 episodes that we've really explored behavioral health. So I'm really excited for the whole conversation. So jumping in, I would love to start with the big picture, and thank you for that deeper introduction. Over the last decade, and it's probably been longer than that too, but we've really seen the acceleration of behavioral health becoming one of the fastest growing areas of healthcare. And I will say editorially, I'm excited about that because that means we're actually talking about it. For a lot of years, it wasn't even part of the conversation. So what do you think are the factors that have really driven the dramatic increase in demand, and what changes have you observed throughout your career?
Yeah, I got my start in administration in Ohio in about 2013. And at the time, I was managing a freestanding psychiatric hospital that also did a lot of substance abuse work during the opioid epidemic in Ohio and Michigan and across the Midwest. And since then, fortunately, the opioid addiction has slowed down a bit. We've done a better job of addressing that. But we're still seeing about 1 in 4 adults, or I think it was 61.5 million total in the country in 2024, experiencing some form of mental illness, and about 1 in 6 people age 12 or over having or meeting the criteria for substance use disorder. So while we're seeing some advances in not only programming, technology, and treatment and co-located integrated treatment, there's still a major need and a major demand for both mental health and substance use treatment across the country. I would also say that in the last 10 years, certainly the Affordable Care Act had implications on Medicaid expansion. I think that allowed people to seek treatment more actively, which is a good thing. But at the same time, it just showed us kind of what was under the surface, really what was hiding in plain sight for a long time, which is folks weren't seeking treatment. And when they were given the opportunity to, of course, they did. So that number, that 1 in 4, actually came down from 1 in 5 or 1 in 6. And so the diagnosis rate, just like with autism, we're seeing the same thing. Now that there's more diagnosticians, now that there's more attention on applied behavioral analysis, we are seeing a lot more people seeking treatment through that coverage. And then, of course, we had COVID-19, right? So COVID fully accelerated not only people's fears, anxieties, concerns, it also kind of locked people in place at home, not getting into the office anymore, not seeing family as they were. And so all of the things that exacerbate mental illness or substance use disorder really came to the forefront. And so as telehealth expanded, as people looked at, hey, what are we going to do to address all of these unmet needs? People are really struggling. We're seeing it on social media. People are talking about what they're going through. Those things also really contributed to the dramatic increase, not only in demand, but also then seeking, right, the services and people having the opportunity to develop and build out more of a continuum of treatment. And we can talk more about that as we go.
Oh,
One thing I like to note to people that may not know this, the behavioral health sort of industry or market is slated to grow in value a significant amount. And that's because there's so much investing happening in the space, both from traditional health systems, from insurance companies, and from private equity and venture capital groups, of course. But that amount is going to be about $132 billion for all services by 2032. And so we're going to continue to need a lot more clinicians, a lot more supportive services, and a lot more integrated services, which means more screening for primary care physicians and even subspecialty clinics like we're going to discuss today.
yeah, that's fantastic. Thank you for that. The pandemic certainly shone a bright light on a lot of things, and I think there's
Mhm.
as I reflect on that time period, which is now in the rearview mirror, not quite in our history, but it's in the rearview mirror, that there were some silver linings to the
Yes.
whole pandemic, and certainly the people's capacity to figure out remote work and to potentially find a little bit better balance in life. But also
Yeah.
to your point, shining a bright light on isolation and depression and anxiety and the things that we see folks needing care for. It also seemed there was a big shift in terms of the authenticity of people on social media. It was no longer the A reel, right? The posting all the fun vacations and all of that. It was more a little bit more raw and a little bit more real. And I think that societal shift probably helped with that growth that we've been talking about as well. And thank you for all the statistics you shared too, because I think that's sometimes a little bit lost on practice administrators and physician owners is just we have a general sense for this growing need, but to really have it articulated that way is critical for the audience. So, what do you think as far as the public's perception of behavioral health? Like, how do you see that changing? And then, how do you see healthcare organizations needing to pivot based on that?
Yeah. So I think from a public perspective, TikTok and social media have allowed, like you said, from professional athletes to executives, put a name and a face to a disorder for the first time and really talk about having depression, having a substance use issue, having a child with a substance use issue. And so that's really allowed for an open dialogue and for connectivity in a different way. I think I remember as a kid in the 80s, the campaign, this is your brain on drugs, and the egg sizzling in the pan, any questions? And certainly that resonated with people. It frightened people,
Yeah.
but it wasn't the same as putting a name and a face together and saying, oh my gosh, they're just like me, or oh my gosh, they're experiencing something like I was. And so I think for treatment providers, whether you're a primary care doctor, an OBGYN, an orthopedic physician, you're seen by people who have mental health disorders every single day. And being able to just simply ask the question, how are you feeling? How is it going? How has this illness impacted you? And then saying when they answer, oh, you know what, doc, it's not going so great, saying, hey, we have a solution. We have a screening tool that we can help you with, or we have somebody down the hall that we can introduce you to that's going to take some of this information and really help you make some decisions about what might be useful and helpful to you. And so I think just that opening of the dialogue is critical. And one of the things I tell people all the time is there was one point I was working for a health system and we were looking for a way to engage the community and all of the stakeholders that were involved in the hospital foundation boards. So a lot of business people from
Yep.
around the communities that we were serving. And we said, what's the best way to engage them around the issue of mental health and helping them to understand that we need some money for the next year or 2 years to fund some nurse practitioner positions, some licensed clinician positions. And what we ultimately decided was to do a campaign that was built around people who had regular everyday problems, such as how to pay their bills. It's a typical stressor. And so what we did was we took an example like, are you somebody that has financial discussions with your spouse at home after the kids have gone to bed? And how is that impacting you and your functioning? And are you somebody in the suburbs who has a great kid who's in high school, but you started to notice some changes of isolating in their room and you've started to think, I wonder where that $20 went that I gave them because I don't see anything that they bought or anywhere that they went. And so maybe we should get them assessed for a substance use potential issue. And subsequently, the third example we used was around a mother, brand new mother, who was so ecstatic and excited to celebrate a new birth and bringing a child into her life. But underneath it, we had the little voice in her head asking, how am I going to do this? And am I really cut out to be a mom? And I'm scared. I don't know how to do this. I don't have the support I need. And so that sort of postpartum issue that we all wrestle with as new parents and speaking to my spouse when she is a new mom. And so those three examples are just ways that people have common everyday discussions about the ways mental health is affecting them. And I think that alleviates the stigma, that normalizes the mental health discussion into that way we're looking at today, which is mental health is a huge part of healthcare. It's not separate. It's not supposed to be separate. It's an element that must be addressed in conjunction with total health, part of the ecosystem, et cetera. So that's what I would say about what's happening today in terms of how things are looked at.
Yeah, that's fantastic. And it's great perspective for practices as they think about how to
Sure.
view behavioral health as part of totally comprehensive patient care when we think about
Mhm.
taking care of the whole patient. And I love the three examples that I mean, those are all so real and close. So if you haven't experienced all three yourself, then you probably know someone or someone in your family who has. So that's a great segue to just think a little bit more about the term integrated behavioral health. And I'd love to hear how you define that. And from your perspective, what does a successful integrated model look like inside of a physician practice?
Sure. So to me, integrated has always meant you're going to be handing something off to another professional and not just making a referral. In a lot of cases, people talk about a referral needing to be made to see a specialist. And that's been the way that medicine has functioned for a long time, right? You need that PCP referral to go see the orthopedic specialist, or you need to go see that psychiatrist. And in this case, really integrated behavioral health within, let's say, a primary care practice means that you have that professional as a part of your treatment team. They are not doing something outside of your normal treatment planning. They have access potentially to your electronic health record. They are brainstorming and problem solving along with you as the primary care provider and your team. And so you're embedded truly as a part of that functioning team. And so just like when treatment teams round in hospitals, presumably you're doing that whether virtual or in person at a clinic with the rest of that treatment team and really putting into effect that warm handoff, that discussion actively about what's happening with that patient. How can we engage them differently? What do we need to have in clinic to make this a reality or a part of what our workflow model is? And then how do we take advantage of that integrated system of care? Because there are benefits, and we'll talk about that in terms of revenue and return on investment and all those things. But I think the first part is to know that they are a part of your team and not just a referral or somebody that exists in the exterior who's going to magically solve a problem and then your patient's going to come back completely fixed or healed or whatever the case is. So that's really how I would define the integrated component.
Got it. Thank you. And that's an excellent lead in to thinking about adding those services. If people in our
Mhm.
audience don't yet have that, but they're starting to feel the pressure of I need to have a person or a place that my patients can get this care. Talk a little bit about the cost and the complexity and what you would say to organizations who might be hesitant to lean into this and make the investment.
Yeah, I think there's really a three-step model to first assessing where you stand on integration and your readiness to integrate. And part of what I do as a advisor and consultant is to help you do just that, to assess readiness, to talk about what are the startup costs going to be, in some cases to talk about what are the billing complexities that you might be adding, And similarly, what staff might you need to add to do this well and to have that truly integrated approach? And I think one of the best things about doing this today is there are real incentives from payers, from grants federally. So SAMHSA has issued many grants to states, but also directly to organizations who are looking to do this better and to enhance care and to really take charge of some of the clinical factors that lead to worsening chronic illness on the medical side as well as the behavioral health side. And so, whether you're talking about shared savings agreements or you're talking about a true value based care proposition, plus a little bit of fee for service, there's a lot of ways today that have been enhanced to allow you to do that in a much more meaningful way and get reimbursed for it at a pretty good rate so that you're not taking a loss. You're not expected to just make this a service line loss leader, which for a lot of hospitals and health systems for years, behavioral health was always in the red and was where they threw the MRI machine when the end of the year came because it just fit there. Yeah. And so I think for people who are managing practices, that's a real difference today. So that's what I would say first and foremost.
That's fantastic. And I love to hear about how adding such a much needed service can also improve the finances. Beyond the revenue, what are some of the operational benefits that practices experience when they embed the behavioral health into their workflows?
Yeah, I think first and foremost, it allows the physicians, the nurses, any of the people that are already in office and managing our practice to operate at the top of their licensure or their education. Because by having a specialist in that area, you actually don't have to worry about trying to work through something if there's a crisis in the office. You actually don't have to try to come up with all the solutions. You have somebody who is a trusted, trained professional who now takes that burden off of you. So that's the first thing. The second thing I would say is that you're probably going to see a reduction in cancellations, right? So that's a real tangible element to your practice management. And the reason I say that is because when you can solve multiple problems in one location, patients are going to be able to come to you and trust with a lot more than just a single physical ailment or symptom. And I think the reality is that in-person discussion, that ability to see exactly who you need on two fronts in the same place, maybe even during the same hour scheduled visit, that takes a lot of that burden away. And so I don't have to get transported anywhere else. I don't have to pay a second copay. I have time built in here. And this is a trusted team I've gone to for years. And they've added an element now that just will help me further. So from a cancellation standpoint and a physician satisfaction or retention standpoint, as well as a patient satisfaction standpoint, I think all of those things level up when you do that integration for sure.
That sounds a bit like a trifle. That's good when we make all three parties happy, right?
Exactly. Yep.
I love it. Well, let's come back to the money because it's medical money matters. So let's talk a little bit about specific reimbursement opportunities that you're seeing in the market, like value-based care or revenue streams that practices might be overlooking when they're starting to look at behavioral health as a strategy.
Yeah, I think the first thing is it's a new billable service, right? When you add psychiatry or therapy, and that's first and foremost. I think what has happened also is that CMS has moved towards this integration in a way that's meaningful in that the service code, the CPT code, I think it's 99484. I'm referring to my notes because I didn't have it memorized off the top of my head. It is one that doesn't require a psychiatrist to actually do the consultation or be the case manager. And so CMS has actually moved along with the acknowledgement from provider groups that, hey, you know what? It's hard to find psychiatrists. It's hard to find people that are going to be available. However, if we can expand this a little bit to psychologists, to licensed clinicians such as LCSWs, LPCs, LMFTs, the significance is tenfold, right? You're going to be able to see clients, you're going to be able to meet them where they are. And out of that, Medicare has increased that particular code, just as an example, from $48 to $53 over, I think, 2 years, 2 fiscal years. And they're continuing to enhance that code specifically because it allows that sort of once per month check-in at a minimum.
Great.
Now, there are other codes that you can build in that certainly would add to the revenue stream that allow for that every 20-minute checkup, that typical appointment. And they've also allowed LPCs and LMFTs to be a part of that.
Okay.
So now where clinicians and clinics used to say, I can't find a psychologist, I can't find an LCSW, they've actually expanded the workforce to actually help to meet that demand. And so it's getting harder and harder now to say, you can't pay to play, right? You can find the staff, you should have them in your office. And I think from a patient standpoint, that should be an expectation. That's a good expectation to have. So those are things to do. Now, there was a code that I did see previously, which I did some research on, which was specific to FQHCs and the integration with Medicare of co-located and integrated behavioral health that they've actually stopped using. But that's because they'd given them permission to use the G's 0323 HCPCS code instead. And so I think that's a real opportunity for FQHCs because it actually reimburses at a higher rate than what they would have previously gotten to do the same sort of thing that I'm describing. So really, there is incentive financially to build this in, to utilize those specialized professionals, and to hopefully help yourself by generating some more revenue, which then you can return, whether it's in capital form or people form, adding some more clinicians to do some more good work, whatever it is. But there should be opportunity for a lot of people out there.
Absolutely. It seems like and given the examples you gave early on, the demand for behavioral health is only going to grow. So yeah, absolutely. Thinking about practice administrators and physician leaders in the audience who might want to begin integrating behavioral health services, but they're kind of starting from ground zero, what are the first 3 steps you would recommend? And then maybe also throw in some common mistakes that they could avoid.
Yeah, there's definitely some mistakes. I'm trying to think if I want to frame some models that they could think about, but I think the first thing is to consider what's out there and what's being done and what's working, and then to move to assessing where your physicians and where your staff feel like there is the most need and the most demand to support the patients that you have at your practice, right? You can't do that without actually thinking about these are what our patients need most. This is exactly the type of therapist or clinical professional that we need. And so I would start there. Where are you on the integration continuum, right? Is there any other service that you have workflow for that's already in place that you could mimic and just build in some new billing, coding, and professional staff, and instead of trying to reinvent the wheel? So I think that's part of where you want to start. And then, are there physical plant changes necessary to do the work? So do you have the office space? Do you have the technology that's needed? Do you have the assessment tools that might be required? And if not, can you get them through your electronic health record vendor? Can you get them through the APA or the AMA? Whatever the case is, you need to do some research about where are you going to get some of those tools, and then how are you going to work them into your actual workflow and day-to-day processes so that the professionals in the office understand them and where they apply and how you do that well. The second thing after choosing the model that I would say is always around billing, coding, and payer conversation, right? So you may have great contracts established. You may already have a great value-based contract in place. However, it may not include behavioral health. So you got to go back to those contracts, to your reps, and say, hey, we're really thinking about this. What would this look like? What would need to be different from your end? And what are the things you're going to want to measure and have us report out? And then understand how that fits within that first question of, what do you need for your patients? How do those things fit into what they're talking about? And maybe make that list, a short list of 5 things of these are the things we're going to have to measure, focus on, and do. And now let's talk to the payer about what is the language around that? What is the opportunity for incentive payments? What is the opportunity for shared savings? Because maybe you're already working with lots of diabetic patients, diabetes type 2, who also have depression. That's one of the top issues that healthcare and insurance are trying to solve for, is keeping those folks out of the ER, right? Not having diabetic crisis, not in inpatient psychiatric facilities. So together, that's a real problem that they want to solve. So they're likely to incentivize those types of contracts. So I think that's, and then the auditing is the other component that I always speak about, right? How do you audit for the scheduling of these services? How's it working? Is it being done timely? Is it creating log jams in your workflow and your office visits where it didn't before? And what things do you need to identify and work on and fix and tease out as a result of that? Reportable KPIs is a big one. I think behavioral health as an industry has struggled over the years to say, these are our core measures. This is exactly what we want to see every single patient, every single time. And so now payers are working directly with providers to establish that and to set that up. And so you may even have the opportunity to participate in a pilot and get something going and be at the front end of some real great incentive opportunities. So that's the other way to look at it. And of course, Jill, that's where you come in, right? Your company helps to set people up with fantastic trainings and
Yeah.
understanding coding and understanding why these are so critical things, not just to update on an annual basis, but quarterly, biannually, right? Sitting down with those clinicians and the office staff to say, hey, are we maximizing how we do this? Are we doing it the right way so that we are getting the right billing out and we're getting the right reimbursement?
Yeah.
So that's a huge component as well.
All of those pieces, yes. And I was going to say, you mentioned the payers in there. I was going to say the credentialing is one of the bigger issues we see
Oh my gosh. Yes. Thank
still
you.
with behavioral health, really any kind of clinician, but behavioral health especially is. And I had a conversation with one of the health plan leaders here locally, and she asked me, what is one thing we could do that would make it easier? This was shortly after the pandemic. And I said, just shorten up the credentialing timeframe. That would be a lovely thing to see. But at any rate, this has been a fantastic conversation, Ed. I want to thank you. And I want to ask, I want to let everyone know we will have all of Ed's contact information in the show notes, so you'll be able to find him easily. And so one final question I would ask is just any pearls of wisdom that you want to share. You gave a really great blueprint, but anything else that occurs for you that our audience should know about adding behavioral health?
Yeah, just that behavioral health is a core component of healthcare. And if you're ignoring it or you're not addressing it, it's going to hinder your practice. It's going to hurt in the long run and it's going to impact people's health outcomes. I would say if you want to make a dent truly on the ED utilization, if you want to look at things like looking at substance use disorder and the impact of treating somebody's anxiety and substance use and a chronic condition, they're directly correlated. There's lots of great research out there. I am happy to share with people who want to reach out to me where to find articles that can help justify changes in what your practice is doing with the clinicians in your office. I can help you with things that have been published year after year to demonstrate the efficacy of these services and how important they are. And ultimately, my goal and your goal, hopefully, is just to have people be healthier, and together we can do that. So I appreciate the time, Jill, very much.
Wonderful. Thank you, Ed. So appreciate having you here today.
Yeah, thank you.
Before we wrap up, if you're listening to this and thinking, it's not just one thing, there are multiple parts of my practice that could be running better, I want you to know that you're not alone. Most physicians were never taught how to run the business side of medicine, and yet you're expected to lead complex, multi-million-dollar organizations. That's not a personal failing, it's a systems gap. At Healthy Practices, our operational and strategic consulting is designed to help you close that gap. We work alongside physicians and leadership teams to bring clarity to the business. Everything from workflow and staffing models to financial performance, growth strategy, and long-term planning. The goal is to help you move from reactive and overwhelmed to structured, intentional, and in control. For some practices, that means solving immediate operational pain points. For others, it's about stepping back and building a clear strategy for sustainable growth, profitability, and leadership development. And often, it's both. Because when your systems, your people, and your financial performance are aligned, everything gets easier. Decisions become clearer, teams function better, and the day-to-day stress starts to come down. So if you're ready to take a more intentional look at how your practice is operating and where it could go next, I'd encourage you to reach out and start the conversation. You can find more information in the show notes or at healtheps.com.